Hi, everyone, and welcome to our May edition of our Q&As. We are so happy that everyone's here, and I have to tell you, you need to pat yourselves on the back because we had so many questions submitted this time. Woo! Everybody gets applause, standing ovation for everyone, because we have a full agenda, right, Sen?
Yes, we do.
And that is Sydney Kraft. She's my business partner, and she is an expert in many things home health. And we are so excited to have everyone on. Cindy, here we go. Question number one, review choice demo scheduled to end 5/31/24. Any info if CMS plans to continue or expand to other jurisdictions?
Feel free to take that one, Sherry.
Many of you are subscribers to our newsletter and our emails that go out each day. And I just put one out the other day that was informative to the fact that review choice will be extended or has been extended for another 5 years. And it did not expand to any of the states, but there is one minor change in the options that you can choose as far as how you are reviewed for review choice demo. They took one of them away. And we find it very interesting. Number one, that it expanded for 5 years instead of a shorter time frame. And in another thing, Sydney and I both agree that we think this will expand to other states, but there's an interesting caveat to that, right, Sid?
Yeah, I think some of the challenge of expansion versus extension is the fact that this still remains a project directed by Palmetto as the intermediary. So we know that many of you may have an intermediary other than Palmetto, and I think that's part of what is still kind of the how do we move this into other intermediaries to replicate the process that Palmetto has developed in spearheading this. So I think really the extension to the current states is more about buying some time potentially to go into the other intermediaries or simply to continue to add states within Palmetto jurisdiction in that 5-year period.
Yeah, and again, part of this, part of their decision making has to do with the number of people that they have hired and trained to do this process. Because as it is somewhat laborious on the agency side, it is equally as laborious on the intermediary side. So keep an eye on this, and particularly if you're in the Palmetto jurisdiction, if they are your fiscal intermediary, I would pay super close attention to your state possibly being next, because Palmetto has a formula and they may expand that formula. We know that CMS likes this program, this demonstration, because we think that the main reason is that they're getting better quality claims at the end as the result of requiring this affirmation at the beginning. But I want to caution everyone, this does not equal no denial. If you get an affirmation to start a service, to start home health in those states that are covered by, that are in RCD, that does not protect you from an audit on the other end after you submit the claim. So please be diligent about what occurs between that start of care and that affirmation and the discharge and before you set your bill. So that's my public service announcement for that. Cindy, you ready to move on?
Yep.
Okay, number two, what is your take on Palmetto's mandate that documentation is necessary to show the handoff between a doc A to Doc B at research if the physician that will certify home care changes?
Sherry, I think that that is another example of things that should be happening because they're the right thing to do, ending up in some sort of rule. Because it's not being seen consistently or it's been difficult to identify. I think that that was the primary driver that led to our wonderful world of face-to-face requirements. Because if you think about it, the information we're trying to get, what is the reason for care, homebound, those different elements are things that should be on a good referral. We were dealing at that time with the whole, going on a name and an address and trying to figure out the rest of it by retrofit that, face to face is still a challenge for many of us, but the concept is we'd really like to have that kind of information from the physician. I think we're seeing it happen now with respect to this handoff is it really occurring? Is physician A aware of the move to physician B in terms of who's going to be taking care of this after this handoff piece? Now, it did say, Sherry, what is our take on, which isn't necessarily let's just talk about the rule. My take is we have the right to be a little bit aggravated. Because much like face-to-face, these seem to be requirements pointed at us that really shouldn't be our responsibility. I mean, if the doctor's the one making the referral to home care and there are certain things that need to be in it, then it should be in it. And if it's missing, that should be on the physician, not on me as the home health provider. And that's what I see here is, wait a minute. So Dr. A is handing off to Dr. B to certify home care changes. And now I have to make sure that I have specific documentation in my possession that this occurred. Okay, it
Right.
just seems like a variation on the theme of, yeah, I should, but shouldn't the physician be the one driving this? And if the physician is, if I don't have this documentation or that it isn't exactly what they're looking for at the moment, I'm the one responsible that this handoff didn't occur. So I think that some of the, you know, again, it seems to be the pattern we end up with some of these rules or decisions to force the hand of people that weren't necessarily documenting things correctly or weren't getting necessary pieces on a referral. But it does feel like something that is annoying. But I think once we find our footing in terms of what that documentation looks like and what Palmetto is looking like, it shouldn't be long-term a hugely laborious process.
I agree. And Cindy, I got a direct message asking this question. When is the handoff mandatory to be completed? The documentation piece of the handoff. And I'm going to say, as soon as you find out, as soon as you find out there's a change, I would just create another verbal order or another written order to go out with your plan of care. And there is some precedent for putting this information in the new plan of care, particularly at research. Physician A was this, physician B is now this, both have been made aware. That type of verbiage is important. And again, I think this is another opportunity where they're asking us to clean up for the docs. We know that people go in the hospital and oftentimes the primary care physician is not notified, as they should be, that their patient was hospitalized, and the hospitalist has a responsibility to do that. However, I don't think it's happening. And I think this is part of what they're handing off to the home health agencies. So, any other questions, Cindy, on that, or any other statements?
No?
All right. Moving on to question 3. I was just informed that an order for home health does not have to have disciplines on it. It only has to say home health, and then the started care clinician can determine which disciplines are needed from there. Thoughts?
Okay, I like the ones that say thoughts versus what are regs. I've been in the home health space now for almost 30 years. And historically, again, before the days of face-to-face, we would get orders that just said home health. What I always found interesting, Sherry, is somehow that always meant a nurse.
Right.
And it's like, wait a second. So you're saying that the start of care clinician can go determine it. I'm pretty sure you mean the nurse. Because if you're saying it doesn't really matter what's on it, then why couldn't the therapist go first in terms of this? So that's a little kind of, you know, what pinged me there was, yeah, I really don't think that a referral that just says home health meets the expectation with respect to what disciplines are really necessary for the patient. If you think about the primary driver of the face-to-face is the physician is supposed to be driving this referral. And home health, you know, I always interpreted if that was the content of the order was basically code for, please give this patient whatever they want so they leave me alone and stay out of my office and don't call me anymore. But I think to that end, regardless of the specificity of discipline, and my thought is we should have a discipline specified with respect to who's going to be through the door first. We don't know with that home health, did he mean all of the services? I mean, are we really saying that order is nursing, PT, OT, ST, aide, and social worker? You're still saying there has to be some discretion there, but there always is that opportunity that no matter what service is ordered to open this episode, there should always be eyes and ears looking for the opportunity of this patient to benefit from other services. And Sherry, you know, this is partially why, not directly related to the question, but my quick soapbox is I absolutely hate the term therapy only.
Yeah.
I do, because it sounds like If this is a therapy only referral, I can't put a nurse in, or I shouldn't put a nurse in. Or if I go out on a therapy only referral and find the need for a nurse, then intake messed up or referral messed up. They should have gotten the nurse from the beginning. I think that this question, yes, I do believe it should be specific in terms of those disciplines. As a good faith, this is what the physician believes this patient needs from the home health agency. But from there, if we see something different, if we see something necessary that wasn't ordered or was ordered and the patient's refusing or deems it unnecessary, then we communicate back with the physician to get that amended. As a former agency owner, Sherry, do you have any thoughts about an order that just says home health?
I think that that kind of takes us back to the olden days. And Cindy, do you mind turning on your closed captions? Because apparently everybody is seeing mine, but not yours. But the other thing I'm going to say about the very generic eval and treat for home health, right? That's what we always saw, eval and treat. I think that it's super important that you have policies and training for whoever is going to do that start of care if it doesn't have a discipline on it, and what things they're going to look for specifically to pull in the other disciplines as needed. But I'm going to flip this one on its head a little bit, Cindy. And I want to say something to folks and say, okay, but conversely, can you pull off a discipline if it has been ordered on the start of care, and what's some of the issues surrounding that?
Sherry, I have my apologies. I'm trying to figure out how to turn my captions on.
If you go to your more button with the info, you can turn the pull it down. It'll say captions. Just turn it on there. And I know that folks are listening. I've seen a couple language changes on the closed captions, so hopefully folks are able to get this as much as they possibly can.
Well, let me try talking and see. There, okay. I can see it now on mine.
Awesome.
Sorry, can you, I can only do so many things at the same time. You got me cutting and pasting in the chat box and turning on my captions and asking me questions. I do have a multitasking limit, so can you repeat that properly?
What I was saying is, if you take this issue and flip it on its head, at the same point, you don't need those disciplines to start a case, but you want to be specific on what you put in the hands of that clinician that goes out the first time to query and look for in order to decide whether those other disciplines should be brought in. But then on the flip side of that, what happens if you get nursing, PT, OT, speech on a referral, and the nurse goes out and does the start of care as she should, and in that situation wants to decline the other services? What are your feelings about that, Cindy? We see that way more often than the first.
Well, I find it interesting, Sherry, that in PPS, we did not see it as often as we saw come up now in PDGM with things like, oh, I don't think someone needs PT and OT at the same time, or can't we just push one into the next 30-day period? I think we have to be very clear about if the patient needs any service, what is the appropriate timing for that service to be added in terms of the patient need. To arbitrarily say, I'm just going to take one of these therapies and punt them into the next 30 days can present a risk to the patient in terms of what their mobility or self-care issues are that need to be managed. But I've long thought that if this service is ordered and declined by the patient, the opportunity should still occur for that respective discipline to contact the patient to have that conversation before the order is removed. I mean, okay, if the patient's adamant, like, oh my gosh, no, I don't want, okay, if they're going to be completely belligerent about it, I get it. But I always felt that that discipline deserves the opportunity to try to explain this to the patient in terms of what it is, what they could help them with, what their needs may be. I had a recent family member experience home health, and the order was for nursing, a PT and OT. When the nurse called and said it was PT and OT, my family member said, well, what do I need the OT for? And the nurse simply said, can you dress yourself? And the person said, yes, I can. And then the OT order was removed. You and I both know there's way more to it than did you get your clothes on today. And so I've always felt, even if it was a PT admit, and I think this patient needs to have nursing and the patient's hemming and hawing, and I don't really think so, I would still want the nurse to call the patient and be able to ask more pointed questions than I'm capable of to determine Have we given this patient enough information to make an informed decision? Because I think with the therapy, Sherry, they think we wear spandex and carry whistles and we're going to come out and torture them with exercises when they don't feel good. A lot of times they don't understand that we need to see them at their worst to be able to troubleshoot how to get them better than that, if possible. And so I think there's very much an inclination to, I don't want that. And I've always felt, and I'll stop because I could almost take up this whole time slot on this, is why on earth are we asking patients if they want therapy? Nobody wants it. I don't want it. We become therapists to inflict it on other people. But want it, I mean, would you tell the patient, look at their med list and say, do you want to take your blood pressure pills? Do you want to take your insulin? I mean, and if the patient is saying, no, I don't want to take my insulin, I'm not going to take my insulin, I doubt we'd go, oh, okay, the patient refused, document that and move on. I mean, we would try to make sure the patient really understands the potential ramifications of that decision.
100%, Cindy. I can't echo you enough. And I'm going to just put out a bold invite to any occupational therapist that may be on this session today. Please reach out to me via email because we want to get you on an unfiltered podcast so that we can put to rest this myth that all you do is help somebody learn how to dress or bathe. Occupational therapy is way more vast than that. And there is a lot of things that they do that needs to get trumpeted out in the biggest way. So please reach out to me because we'd love to have you on those on a podcast or many podcasts, because we're big believers in occupational therapy. We're big believers in physical therapy, obviously. And we're big believers in nursing. So we just need to understand each other's discipline better and do what's best for the patient. Right, Cindy?
Yep.
Okay. Number 4. Can you clarify a question that I have on a therapy-only start of care? When a therapist does the start of care and no skilled nurse is ordered, we have been having an RN call the patient caregiver to review the medication list for accuracy and instruct on high-risk medications within 48 hours of the start of care. I was recently listening to a webinar that said we no longer need a skilled nurse to do this if we have a therapist that has been deemed competent in reviewing and educating patients on medications. Is this correct? And is this something we need in a policy?
Well, the short version, compared to some of my other answers, is yes, they can do this. This was a update to the surveyor manual related to the conditions of participation that clarified something that they had misrepresented previously. The previous guidance had indicated that a nurse must be doing this. They have since, after many years of folks trying to advocate to get this remedied, a nurse is not required to do this. So that being said, I think a key piece of the question is a therapist we deem competent in this. So I love that part of the question because I don't want to, and we talked about this, I believe, on the last Q&A, Sherry, that we don't want to see, oh, therapists can do it. You start doing it tomorrow.
Right.
If this is in a situation where you've kept me out of it and had someone else do it, then you're going to want to make sure that I know how to do it and what I'm looking for. And ultimately with that, Kat, I always think part of it should be, you know, if I get into it as a therapist and this is a, you know, 5 med list, and these are things the patient's been on a long time, I'm very comfortable with this. This is good. But also with the understanding that if I go in there and it is a 27 med list and the patient is extremely confused about this, that this may not be just a phone call to a nurse, but I'm going to be pursuing an order for the nurse to come out and take a look at this in person, because my job as a therapist is to screen for medication issues. And saying, well, I can now do more of this at the start of care and I don't have to call a nurse. We don't want to behave as though we've shut the door on that.
Mm-hmm.
Because there are very clear situations that this went in as no nursing ordered, and I'm looking at this med list and all the pills poured in a bowl like a candy dish, and the patient doesn't know what half of them are. I will, without hesitation, grab that phone and get an order for nursing. But from a policy standpoint, you have to go back and look at them, because if you have policies that say a nurse must do this and does X, Y, or Z within 48 hours, then you're going to need to have those policies updated if this is the path you're going to take now. Because if you hold a more aggressive standard than any rule, your surveyor will always hold you to your policy standard if it's more aggressive. So if you leave it with, this is what we're going to do, and then you start to have therapists do more of this without it, you could run a risk on survey, despite the interpretive guidelines, that you are not following your own policy.
Okay, and we have a question that came in on our first question, Cindy. It asks, is Palmetto's new handoff requirement just for RCD states?
It is my understanding it is not.
That's my understanding as well. Okay. Any other statements? I'm sorry to jump in there on that one.
Nope.
Any other statements? And when talking about competencies for therapists, I got my degree for being a physical therapist assistant in 1998. That's been a while now. It's scary how long ago that was. And one of the classes that was mandatory for me to take was medication management and the therapist. At that point, it was much more about the medication classifications and how they impacted the therapy provision. But that was back in 1998. I know that it is part of the curriculum for therapists that have come out of school in the last 4 or 5 years, but just like anything else, you would not send a brand new nurse out to do a complicated infusion without training them and deeming them competent. You wouldn't send someone brand new who'd never seen a wound vac and ask them to do a wound vac on a very weird sacral wound that's very difficult to seal. You just wouldn't do that. And so thinking about this in that same vein for your therapist, occupational therapy, speech therapy as well, that we want to make sure that we get those competencies in place and hold your staff to that. I mean, you're going to have the folks that are better at it than others, and those that can possibly will gravitate towards being very, very good at medication management. So using your staff and playing to their strengths is super important. Cindy, did you have anything else on that one, or are we ready to go to number 5?
I think we're ready to go to number 5.
Okay. Number 5, this is another long one. Guys, these questions are fantastic because they're getting to the heart of some of those really difficult issues in home health. So thank you again for submitting these questions. Is a policy required to use the accepted order to allow care to begin and use the newly created plan of care? Example, patient is admitted on 6/1/24. We have an order to admit for recent admission to hospital for CHF exacerbation. They need nursing, PT, and home health aid. The RN completes the comprehensive assessment and creates the plan of care. They call the provider's office and request an order for the RN for 2 times a week for 2 weeks, 1 week for the home health aide for 2 times a week for a week. Doesn't say how many weeks. Okay. RN for education regarding new medications prescribed in hospital and education regarding disease process regarding CHF diet and HHA for assistance with bathing and grooming as patient regains strength and endurance post-hospital stay. RN documents that is this in a clinical note in the patient's chart with a date and time and a verbal order was received from the physician. Can the agency begin care based on this verbal order, or do they need to wait for a signed verbal order or signed plan of treatment? Do they need to have a policy stating they can begin care with a verbal order?
So Sherry, I am turning this back around to you because I think it's a platform for some of the discussions we've had lately around the whole verbal order use.
There are so many things you can do with a verbal order in home health. I think it's extremely underutilized, but when it is utilized, it's done wrong. I want to be very clear. There is a formula for a verbal order. It states who you spoke to, what time you spoke to them, what you discussed, and what was cleared up on the verbal order. At the end of a course of care, at the end of an episode or a period of care, say the 30-day period, you have to have those orders back signed from the physician before you can bill. But yes, short answer, yes, you can absolutely provide care and changes to care on a verbal order. I know that a lot of clinicians get frustrated with having to call the physician from the home and having to make those extra steps. But please, please, please know that a verbal order stands as it does in every other setting that we work in. We just need to make sure that it's signed and in place before you do that, before you process the first bill. Did I make that?
Yes, that's the point I wanted you to hit because that's where I think some people get stuck is the difference between, it needs to be signed. It needs to be signed within that time frame before you drop the bill. But it would defeat the purpose of a verbal order in concept if I still couldn't do it until I got it back signed. Because that would delay the care and to me, it wouldn't make sense that the power of a verbal order is that I can get all of that information and act on it accordingly. But I just want to reiterate, Sherry, it has to have those key elements in it.
Yes.
When
Yeah.
I see just verbal order for, okay, but who did you talk to? When did you talk to them? I think that's where folks may have encountered directly or indirectly, getting in some sort of trouble because the over a verbal order issue that wasn't the concept. It may have been information lacking in the verbal order itself.
And there is a way that you can add that into the plan of treatment, into what we used to call the 485, which is the plan of care. You can add that verbal order language to cover you as well. So you can get covered twice in that situation. But I think it's really important that you create that verbal order. And if you don't want to barrage your physician with a verbal order, you just want it to be the plan of treatment, you can put into a communication note that verbal order was seen, processed, and placed on the plan of care for treatment or for signature. You just need to write the captions, if you will, of what happened with that verbal order and how you plan on getting it certified, which is the signature. But yes, care can occur on a verbal order and should occur on a verbal order. The types of patients we see and the surprises that we find in a home, we need the verbal order. So please just, shore up your policy and your competencies on who can do a verbal order. Let me be very clear. Everybody can do a verbal order except for a home health aide, a PTA, and an OTA in home health. Let me say that one more time. Everyone can request and receive a verbal order except the home health aide, the PTA, and the COTA, the COTA. We can, as a PTA, a COTA, and myself, we can only take orders from a PT or an OT. So just really clear.
Sherry, I want to, before we leave the verbal order though, because you and I see this a lot on our outsourcing services with our clients, is the role of a verbal order if I have a discrepancy with the face-to-face. So the face-to-face came over saying that it's for heart failure. The clinician goes out, does a thorough assessment of the patient. Yes, they have heart failure, but that's really not what we're going to be focusing on because their diabetes has gone completely bonkers. What's the possible use of a verbal order there?
Possible use is to increase their medications right away via verbal order. I mean, you can make the difference in a hospital stay. You can make the difference in them having to leave the home for some other reason. The possibilities are endless with a verbal order.
So can I clarify and basically addendum my face-to-face using a verbal order option of, once again, who did I speak to? When did I speak to them? The nature of that conversation and agreement that this is now going to be the focus of care.
Yes.
Okay. I wanted to make sure that got out in this Q&A because I think verbal orders very often get discussed in the context of more clinical things like the question described.
Mm-hmm.
And we sometimes forget that we can handle that issue of a primary diagnosis. And we always say, if you think about it, again, more clinical, if I'm the clinician and now I have determined that diabetes is going to be the primary driver of this plan of care, I would need to contact the physician regardless because they sent it over for heart failure. And if I'm going to make a substantive change to this plan, then I need physician involvement anyway.
Right.
So that verbal order properly written can also take care of the face-to-face alignment issue and expedite your coding. And if you're in review choice, expedite all of that by having it line up right away.
Exactly. And I think that, we all learned how to do verbal orders back in the day. We just have to go back to those basics. And if it's going to be a face-to-face update order, like you mentioned, you have to understand that you need to title that order, verbal order taken for face-to-face update, plan of care update, and then list out what it is. So explaining that verbal order as much as you possibly can is key. And I think that we just need to take a step back, go back to those basics, get those pieces and parts, go via the recipe and remind folks that, a basic verbal order, that just is very wide open is not good enough. You have to be very specific. Cindy, any other statements on that?
I don't have any.
Okay. Number 6, right? This one's not nearly as long. Okay. What are the home health time frames or recommendations to complete? Number 1, when a new discipline is added on mid-cert period. Number 2, for resumption of care. What are the time frames to complete all the disciplines on the order?
So I think this has kind of been a long-standing issue with respect to start and resumption of care and what are rules. From a rule standpoint, when we see this concern about timely initiation of care, they're really consistently referring to the initiation of care. So that qualifying service going in first, establishing this, doing the comprehensive assessment, we know that the expectation is for that visit to be completed within 48 hours of the referral, or if we have a physician ordered start or resumption of care date, then the expectation is if they told you to be there on that date, that your start of care date is going to match that. I think what's happened is we've taken that and then we've tried to say, what are those time frames for anybody else ordered? So let's say it's a nursing and therapy case, nursing has gone out, they've done the start, they've done the resumption. That date on that OASIS is going to be measured against the physician ordered start of care date or the date of referral that was provided. The rest of that team is not held to a specific time frame. It doesn't say everybody has to be in there within 48 hours. I've seen that over my time in home health, the whole everybody must get there within 48 hours. That's not how regulations read. So to my knowledge, and if someone has found something in statute that says something differently, I'd love to see it. But other disciplines involved are not held from CMS's perspective to a definitive time frame. That being said, we want to be reasonable about this.
Mhm.
So when I see, the order is for, and I'm sorry, this is typically where I find it, it's for nursing, PT, and OT. Nursing does the admission, PT's out there in 2 days, OT's out there in 2 weeks. And there's no explanation. There's no paper trail that the patient requested it to be that long. There's no evidence there was contact with the patient about this being 2 weeks from now. It is going to be a question of why did it take 2 weeks to have the OT come out and do an evaluation? So I've always looked at it and said, okay, what is reasonable? And very often in talking with many agencies, they look at about a 5-day window to say in those first 5 days, that would be reasonable that other ordered disciplines were going out there and doing their assessments and initiating care. And if a patient refuses to do it then, or is very sick and says, can I please wait until next week to do X, Y, or Z, then we make sure we have the appropriate documentation and the physician notified and all that good stuff about any delay. What we have to be cautious of, once again, is what is in our own agency policy. Because if I've put in my policy manual X number of days or X number of hours from that start or resumption of care visit, once again, I'm going to be held to that. And so that's where I've seen agencies, back in ye olde days, the agency I was working for was consistently getting into trouble with the surveyor because, well, it was a conglomeration of things. One, she insisted that everybody had to be there in 48 hours, despite the fact that there was no substantive rule to back that up. But our agency also put that in policy. So we had all kinds of trying to, make sure the documentation was good, the patient refused, all these other rigmarole. And it was kind of like, why are you setting up a standard that is so tight that the patient simply saying, can I do this tomorrow? Or there's too many people here today. Can I do this the next day? Led to, oh, great, that's day 3. Now I have to go update the physician who really didn't care it was a day later, and all these other things that are self-created based on my policy.
Right.
So I would look at it and say, check your policy. Does it make sense? But I would also say, if it's just kind of get there when you get there, it can raise questions from my perspective on medical necessity. And or is this really about what the patient needed, or did you not have anybody available till 2 weeks later? And this was a staffing issue.
Right. And I'm going to just reiterate, there is not a 5-day window post resumption of care like there is for the start of care, right, Cindy?
It doesn't specify that same time frame, but many agencies use that kind of as a guide with respect to if there's other pieces of information to collect.
100%. And a lot of times when folks are coming out of the hospitals, they have multiple appointments, maybe for a specialist that they have to attend or other things that they have to attend. So here's what you have to ask yourself, in my opinion, is you have to ask yourself, and this again, opinion, why am I not sending those disciplines out within the first 48 hours? Why aren't they getting it in a quick time frame? And answer that question in your communication notes about what's going on in the life of that patient that makes it you unable to get those disciplines out. Maybe they're so fatigued, like Cindy mentioned, that they cannot possibly do anything with therapies at that time. In that you maybe the therapist called and spoke with the patient and realized that they're having the worst time since they went into the hospital. Those kinds of things need to be documented, why that delays occurs. But Cindy, you and I both had experiences with home health recently. And if you want to know what happened, because if you want to know the rest of the story, go to our YouTube channel and check out our unfiltered podcast on what happened since the wrap. Because both of our family members had situations, let's say bad situations in home health. And it was just kind of ironic because not only, knowing what we know about home health and how it should be given, to see those kinds of delays and to see those kinds of tactics, it's just hard to watch. And so asking yourself that question, a very important question, why are they not getting these disciplines that have been ordered for them? Just like how you would chase down a medication, how you would chase down a new med if they were all of a sudden put on insulin, you wouldn't wait 5 days to get that insulin and make sure that insulin was in the home, would you?
Well, and the other thing I think, Sherry, is sometimes, if there's going to be a staggering of this in terms of what service, if the patient is overwhelmed or has these appointments or things, what I've never been able to figure out is, why does PT always go first?
Right.
I mean, we are PT, but I've looked at it and said, okay, so if I am really feeling lousy and I just got out of a facility and I have all these things going on and limited amounts of energy, would I want to divert my energy to working on getting myself dressed or going to the bathroom without somebody coming with me? Or do I want to go for a walk? And I know my fellow PTs and PTAs might find that I just insulted my entire profession by saying we're just taking them for a walk. But I think I'm trying to say it from the patient's perspective. And sometimes I think that delay of it's too much therapy, do OT later, do OT next week, do OT. Well, if they're overwhelmed, we need to look at that initial assessment of the patient, and maybe OT needs to go in first and PT needs to cool their jets a little bit. Because what are we trying to accomplish for this patient? And I think, the long-standing joke about OT really standing for other therapy, I think it's been unfortunate in terms of not only is it a utilization issue and in terms of the volume of them in this space, but I think sometimes when we are looking at spreading some of this out and not overwhelming a patient, I just don't understand why PT tends to win that, when maybe for certain patient populations, they should be the ones waiting.
100%. 100%. We're getting some questions in the chat that we may or may not be able to get to, but we will definitely add these questions to our session in July, because they're important questions. And I just messaged someone who sent a really good question about RCD to send me an email, because there are specific guidance that I don't have handy for me to share, but I want to give you the specific guidance that has come out about your issue. Okay, Cindy, are we ready to move on? Because we are flying through this.
Well, real quick though, before we leave it, because I'm scanning through the questions and there's a statement in the chat about collaboration through all disciplines must be 5 days. And okay, you're talking about OASIS requirements. That issue of 5 days is not you must get everybody out there in 5 days. It's saying the clock is ticking from the start, from the resumption. This is the amount of time you have for potential collaboration or revisiting this individual by the same person who did the start to ensure that you have accurate data. Mm-hmm. I don't want that interpreted as all evaluations must be done because this is a rule. That's not what that rule is. That is the parameters for which they're saying this is your time window. So if your other discipline doesn't go out till day 7, their findings are now a week removed from the start of care, and any input they may have about what they saw has basically aged out. It's too far down the road now to say that this is something that would be warranted for OASIS data collection. So I just want to make sure we're clear. That typically is why agencies do say, I want to get the other disciplines out there in that time frame so that they can provide collaboration. But I just want to make sure we're not saying everybody has to be out there in 5 days. That's not what that means. And quick sidebar, let's make sure we understand collaboration is between the people who physically saw the patient. Collaboration is not, I make sure all my therapy evals are done in 5 days, so a reviewer can take that evaluation and use it to change the nurse's answers at that start of care. If that nurse and that therapist don't talk to each other, that's not collaboration. I can facilitate that, but ultimately they have to talk to each other. So let's just be careful. The 5-day window and the 48 hours is about data collection timeframes. It is not about mandatory eval time slots.
At Val time slots, it's always been 48 hours. That's kind of been an industry channel or an industry standard. And I would say very clearly that if it's going to go beyond that 48 hours, again, you need to write down what's going on with that situation, that those patients aren't getting seen within that time frame. I want to add another caveat, Cindy, and I'm going to let you take a deep breath before we start talking about OASIS E1, because this is going to be a special moment for everyone. Cindy has some information that she needs to get off her chest about E1. But any of these PTA, OTA questions that are coming in about what the PTA and the OTA cannot do, I would refer you to the State Practice Act for those disciplines in your specific state. But I have never seen one that allows a PTA or an OTA to take an order from anyone other than their supervising or another PT for the PTA and another OT for the OTA. We are assistants. We're not like physician's assistants who can do things on their own up to a point, but they always have to have that overriding MD. That is not the case with PTAs and OTAs. LPNs, however, in most of the practice acts I've ever read, can take verbal orders, but refer to those state practice acts and remind the PTAs and OTAs, even though you are with the patient probably more than anyone else, you have to run any changes to your plan of care through your supervising therapist. And that needs to be evident in the documentation that they're receiving the proper supervision to do those changes, especially in patients that maybe are medically compromised and there's something that has to be done immediately. There has to be that showing of telephonic communication. So please refer back to those state practice acts. Okay, Cindy Kraft, talk to me about the OASIS E1. And we know it starts January 1st, 2025. But Cindy, what is it that you need to get off your chest about the OASIS E1?
I would really just like to encourage everyone to take a deep breath and don't get sucked into the fear mongering. It is, I understand that anytime a number gets added, it becomes, this is a significant change. It is a significant change for E1, but it literally is only one brand new question, and it's about COVID vaccinations. It's very straightforward. It is not an assessment issue. It is not learning a new technique. It is simply data collection around vaccination. The reason they have to put a 1 is the change is big, but it actually reduces our workload. They're taking all of the goals column out of GG 130 and GG 170. So it's simply removing them. It changes nothing about how we assess it, what the levels of assistance are for GGs, none of it. It changes nothing from a data collection standpoint. It actually is less than, because I'm not having to try to project goals for each and every one of these that I'm trying to collect data on. A couple other things are wordsmithing, kind of trying to get it closer to most current guidance. But I'm getting these questions about what are we going to do? How are we going to train? When do we start training? I think I totally get it, because I think there's some of the aftershock, Sherry, of going to E, because we had to do a lot of prep for E and then deal with it in the beginning of the year and trying to get all of those things straightened out. And we immediately see a 1 on it and go, oh my gosh, I don't think it's that big a deal. And I know, Sherry, we do OASIS education. You would think I'd be jumping up there going, no, you got to buy training from K&K. But the training is going to be small, and the training, I wouldn't be dealing with that till November, December. And here's the new question, and you don't put goals, and that's it. I mean, I don't see this whole what are we going to do panic mode. So my soapbox was just to get the word out. Please keep it in its proper perspective. We have much bigger issues to deal with the GGs and with respect to that discharge composite score dealing that's going to end up in value-based purchasing, dealing with our outcomes, all of these things. I wouldn't spend an extraordinary amount of time or energy worrying about your OASIS E1 prep plan.
I echo that 1,000%. And here's what I'm going to say. You're going to get barraged by all the education providers about how important it is that you provide this OASIS E1 education to your staff and how crucial it is. And it's going to ramp up until probably about December 31st, actually. And everybody sees the new form and they go, oh, that's it. But I'm going to also do a PSA, Cindy, and I'm going to speak on your behalf. Please, please, please don't tank your GG scores. Please, because we have done this as an industry. Anytime they've made a change, we've done things to try and work around it and massage it to our benefit. Please do not have these patients all of a sudden unable to roll in their bed, unable to do a supine to sit transfer, all the other GG items. Resist that temptation. Resist that information that you may be getting from the consultation industry. Collect that data appropriately per the manual. Give the correct information in the picture of the patient to CMS. Cindy, do you have anything else to say about that? I tried to tee you up for that.
No, you said it very well. I'm not accusing anyone who's participating in our Q&A. I've spent time on different technical expert panels and listening to the data around OASIS and how response patterns have shifted repeatedly depending where points are allocated for payment or which questions are outcomes. And CMS notices that when they pick something else, behavior does seem to change. And so with all of this, stop the cuts and CMS is wrong and they're overreaching and behavioral adjustment, my concern is going into this, we don't want to give them one more arrow in the quiver by demonstrating that patients were able to roll and sit up pretty much on their own, starting their home care episode, to suddenly now they cannot, that they need all this help with all of these things. And I know that agencies are taking a good second look at their GGs, and in some cases their first look at GGs. Yes, there's agencies that have told us we're going to have to do some education about those now. They're not brand new items. We got to be paying attention every time point, every item, every time. So I understand that there may be some movement if clinicians haven't been as engaged, if the review process hasn't been as thorough on the GGs, we may see some movement. I'm just afraid of what would really give us better opportunity to make patients better if we made them look worse at the beginning. And the one, Sherry, you know the one because you said it already. My biggest one I'm watching, and I'm having our reviewers watch on our outsource side, is rolling. Because rolling is not related to any sort of fall risk assessment or safety concern unless you think this patient's going to roll themselves and hurl themselves out of the bed. Yes. Or they may, there's patients where this is a problem, but let's not turn it into, if someone is at risk for falls or has these concerns, suddenly they can't roll without supervision. Let's just be careful and reasonable about this. Unlike what has happened with the can you feed yourself question, when it got pulled into outcomes and such with the whole value-based purchasing and rolled into, it doesn't even matter where it landed. All I know is people could feed themselves and then nobody could feed themselves. Right. So it's like we just can't replicate that. And it's tempting and it may look like an easy way to make this better. But I also want to remind us about that score in 2025. It does not talk about improvement. This new model going into value-based purchasing in 2025 about function is not hinging solely on improvement. I know that's hard because STARS ratings has, value-based purchasing of today does, improvement has been the name of the game, and we've been trying to figure out how we get as many patients better as possible. And we've been frustrated because there's patients that aren't going to get better. That's one of the biggest positives of the change in value-based purchasing in 2025 is that predictive score, what you are able to do now and what they predict you will be able to do in the future. That prediction very often for some of our patients is going to be stay the same. They can do it now, and they should be able to still do it when we discharge them. So maintaining their function, and if we need to intervene to maintain their function, maintenance to preserve function will be just as positive an outcome as if you improve them. So the question is whether or not we meet or exceed that prediction. So the GGs are not only shifted in terms of what we're looking at from a data collection standpoint, but they really finally stop this always being about, can I get the patient better at these things, or else somehow it doesn't matter. It doesn't have the same value. This is a big step in that direction.
Agreed, Cindy. And I want to give everybody just another reminder that this is all due to the Impact Act that occurred, I believe, in 2005. And this particular set of questions, the GGs, in one form or another, but the same questions the data is being collected in the hospital, in inpatient rehab facilities, skilled nursing facilities, and us. And so if you see significant inconsistencies, that's going to throw up a red flag. But we're not saying that a person could be rolling independently as skilled nursing and come home and be unable to roll independently, because the equipment, the things that are available in the home, the setup of the home can differ greatly from what they were receiving in skilled nursing or in the hospital. That just needs to be documented well, if that is the case. So Cindy, can you talk just a minute about that?
Well, I always think about the patient, and you know how it's interesting to me, no matter how much time passes, you still have patient experiences that are burned into your brain forever. And that was the patient who was trying to roll on their waterbed. And I'm thinking, you know, and that was so long ago, that was before all of this Impact Act and everything else. I always think of that person when we talk about the rolling issue, because a hospital bed with railings I can grab onto potentially, and I go home and I'm in a waterbed, could absolutely change the dynamic of their ability. So they don't look at it and necessarily say, oh my gosh, because they could do it here, they should still be able to do it in another setting. As Sherry just said, when there's extenuating circumstances, if there's other issues involved, maybe when we did the time of the assessment, after all that's been going on in the hospital, they're feeling even worse. They got home, it's been chaotic. They're trying to make that adjustment. They may need more help with some of these things at that time. So no one's saying you can't do it or somehow we have to match the previous setting, but we do want to be thoughtful in explaining why that individual may need that type of help. And that always goes to my mantra, which is whether it's the value-based purchasing or STARS, is OASIS is simply just the data collection instrument. It's the decisions we make between the measurements that make the outcome happen or not happen. So we're revisiting this in terms of preparation for 2025. Part of it is, yes, I want to make sure you answer the GG items correctly, beginning and end, and consistently correctly. But does our plan of care reflect, if we've identified issues in any of these, are we working on them? If the goal is to stabilize them and there's a very real chance there could be a problem, have we put in a maintenance approach to this to make sure that we don't go the other direction? So that intentionality is a critical part of outcome measures. Not just, did I measure it right? Did I get the data right? I need my data right. But if it's only, I think about it when I'm the one filling in the document and not when I'm the OTA, the PTA, the home health aide providing the care, we're going to continue to struggle with having consistently measurable outcomes going the way we want them to.
Exactly. And I want to tell people, when you scan this this QR code that we have on there, there is a $7 offer that gives you the first session of the series so that you can look at how we're going to present that information. And we've taken a really big look into the size of our webinars and the length of our webinars, so that they can become as engaging as possible and still do the education that's necessary. Cindy, I want to do, we have a couple more minutes. I wanted to get to a couple more questions if possible. These seem to be quickies. Are you ready?
Right.
Okay. What is the correct date to use with a clinician's signature on recertification orders? Is it better to use the date of the recert visit or the date of the first day of the new episode?
Would you like to take that one, Sherry?
I think that it's better to do it the day that you do the recertification. I think that the time frame that you saw the patient is what you probably want to put on the order. Correct. I think that we can reestablish those orders on the plan of care or the plan of treatment for the next episode, and include those verbal orders on that next plan of care if we want to. But I think doing it on the day that you see the patient just shows that consistency of how you're communicating with the physician and how your staff is trained to do it in real time. What do you think, Cindy?
I think part of the concern has been if I do it and it's dated within the current cert period and not the next cert period, could someone look at that and say, well, then you got into the next cert period and that order was no longer valid?
Right.
I typically see that managed by within the body of the order, putting in, this is specific to cert period from X date to X date.
Right.
So I got the order today. I really wouldn't date it the first day of the new cert period, because that's not the day I got that order or wrote that order. So for
Okay.
accuracy, it would be the date you did it. But I think the issue is to clarify, you are specifically talking about what's going to occur between this date and this date, the subsequent cert period.
I agree. Okay, number 8. If a different diagnosis is appropriate at recertification, then we should include that diagnosis. Are we able to add diagnoses at recertification even though the OASIS items have been removed? Where would you update the diagnosis since we can't go back to the start of care?
I am not a coder, Sherry. I'll rant on the OASIS side, but anyone who knows Cindy Kraft knows I am not a coder, nor do I pretend to be, but you in fact are, so take it away.
Those are ordered on those are edited on the plan of care, on the plan of treatment. In most of the EMRs, that item is still left open. The 2100s are still left, 2101, 2102, I believe it is, are still left open. Again, I do OASIS. I am certified in OASIS, but Cindy can correct me on which item that is. But they are still available and they do flow through to your plan of treatment for that new research. I would put them on the plan of treatment. That's where the new one
right.
should go.
So I think that the confusion around this has been on the research, they removed the questions to put them in the OASIS. That does not mean that the coding isn't relevant, because coding at that research does factor in with respect to your 30-day payment periods and what you're going to be submitting around that on your claim and what's going to be on that new plan of care. And so you do want to update your diagnoses as appropriate at the time of research. We would rather see that, again, I'm not a coder, but I do listen to my coders. We would rather see appropriately updated diagnosis at the time of research than leaving things to the point where they don't make any sense. So the UTI that was referenced on the start of care 60 days ago is still showing up here as the primary reason going into the new cert period. Unless something's gone terribly sideways, that should not be the case. And so we want to make sure, despite the fact you're not putting it in the OASIS as you would traditionally expect to do, you do want to take a good look at those codes and say, all right, because we're creating, as Sherry said, we're making a new plan for the new cert period. So the codes that are on that plan of care should reflect, again, what is the primary reason we're continuing into this new episode and what are the relevant secondaries. And if they all stay the same because our plan of care and our assessment supports it, that's great. If something's changed, we want to see that. And that kind of fits, Sherry, in our final moment to one of my biggest things about the plan of care is changing a plan of care based on the current presentation of the patient, whether it's diagnoses or interventions or whatever, shows more skill than just creating very general repetitive plans of care that go unchanged, potentially into multiple cert periods. I've always looked at it and said, if I'm looking at a research plan of care and everything is basically the same, but the cert dates, are we really saying, I made a plan, I worked that plan for 60 days, it didn't work, so I want to do it for another 60 days? The same thing. I would believe if we hadn't achieved what we intended to achieve in the first 60, some modifications would show, hey, this is good faith, this is what's going on with the patient, these are some things that need to change, or I need to resequence this to show that our focus has evolved over time.
Perfect. And Cindy, before we go, we've kept everybody a minute or so longer than we typically do, but we started a little bit later. So what I wanted to say is happy Memorial Day to everyone. And our thoughts are with those that lost loved ones in conflict and in service of our country. And I hope everyone has a safe and secure and absolutely fun opening of the summer beaches, maybe where you live. Cindy, did you have anything else to say before we take off?
No, I always think, do we have enough questions to fill the time? And then we tend to run out of time. So please continue to send your questions. You'll see them show up in other Q&As or maybe the newsletter, or some of them tend to provoke one of our unfiltered productions over on our YouTube channel. So please keep that dialogue going, and we are really grateful for your participation.
And oftentimes they inform our emails as well. When we get an interesting one about regulations, it'll show up in the email so that we can share that far and wide. So thank you so much for your participation. And on that note, we're going to say goodbye this time. And you guys should expect everyone who registered will get a copy of the link for the recording. So look for that in your email, and it will also be in our newsletter blast. So thank you all very much.